Hello, this is Jeff Hauk, and this lecture is on ACL injuries, an update from 2019. We can start by examining an MRI cross-section through the intercondylar notch, and we can see that the ACL sits posterior to anterior right here, and that it's ideally suited to restrain anterior translation. What's interesting about ACL injuries is they typically occur in people when they're active in sports in this middle age range. The majority of them are sports related and non-contact. The mechanisms that occur that are non-contact include jumping from a land, planting and pivoting, and deceleration. You can see here this constitutes like nearly 80% or more of all of the different types of movements. You can also go up from a jump, hyperextension, and then some people can't remember. This is data on the ratio of female to male, and it's a little bit dated from 2007. You can see the overall ratio is females are 3.62 times more likely to be injured than males, and you can see the absolute exposure rates here. So this is the rate of injury per exposure. And then you can see the offset in ratios across the different sports, and here one would be an even ratio, so we can see that lacrosse and skiing, the injury rates are about the same in male and female, but then for basketball, indoor soccer, and rugby, they're much higher in females. This is new data from 2015. It's again injury rates per exposure, and we see that we have males that are solid and the females are hashed because they're more complex. And we can see essentially the red zone here is injuries that are one tear per 4,000 to 5,000 exposures, so the highest tear rates, and they're occurring in basketball, field hockey, men's football, gymnastics, and lacrosse, and then women's soccer. Notice the marked difference between men's and women's soccer. Now, what's interesting is that this is data is in this study from 2009 to 2013, and there's trends toward decreasing injury rates, but they're not very strong. And that's important because this same time period, there's been a really high enthusiasm for implementing and attempting to stop or retard the number of female ACL injuries. And essentially what this data is suggesting is that it's good but not great. And this is a systematic review of 10 studies, and what you can see here is that essentially it appears that there'd be some success for neuromuscular training programs. Noting here there is moderate evidence that multifaceted neuromuscular programs kind of have some effect in preseason, moderate evidence that programs in season do not reduce ACL injuries, and there's moderate evidence that neuromuscular programs that only utilize proprioceptive and plyometrics do not reduce ACL injuries. And then there's several confounding variables, study limitations, preclude definite conclusions in the effectiveness of neuromuscular training, which led these authors to suggest that while the majority of studies in this systematic review suggest a trend toward a reduction in ACL injuries in female athletes using a neuromuscular training program, we cannot yet fully support its use because of the overall lack of statistically significant evidence. So this leaves us with the idea that we should really take another look at the biomechanics of ACL injury and see how that could motivate different prevention programs. So to start with, we want to note that the ACL has two bundles, not one. So here's the femur, intercondylar notch, lateral, and medial side of the femur. Notice that there's two bands of the ACL. The deeper band is the posterolateral bundle. The more superficial band is the anteromedial bundle, and here you can see the tear rates with different kinds of bundle injuries. 75% of the case, both bundles are injured. 25% only the anteromedial bundle. When both bundles are injured, the tears occur at different points. And then there's two tests. Anterior instability is more associated with anteromedial bundle, and then a rotation is more associated with the pivot shift test. So you can see this angulation here means that posterolateral bundle is really what controls the rotation more. And the advocate for really a double bundle repair, and the focus on these bundles is a doctor from Pittsburgh named Freddie Fu. So if we just again take a look at the basics of the ACL and remind ourselves that not just the ACL doesn't just restrain anterior translation, but also internal rotation. And this look really captures its limitation or restraint of internal rotation well. Now, what else does the MCL do? And can the MCL or other ligaments kind of compensate for what the MCL does? And the answer is to some degree, yes. This is an older study that involved robotic testing where they took a knee joint and applied an anterior force at different knee flexion angles. And you can see the different knee flexion angles down here. And then the force that was taken up by the ligaments, the ACL, the MCL, and the bone was tracked at these different knee flexion angles. So in this case, the knee's intact. And what you can see is the red's the MCL, the blue is the ACL, and the bone is white. And as you go from 0 to 60 degrees, the share of the load of the anterior force shifts from being primarily ACL at 15 degrees in full extension to where by the time you get to 60 degrees, bone and the MCL have become stretched, and they're taking up more of the anterior force that's being applied to the tibia. So what this leaves us with is a clinical pearl, and the clinical pearl is this: when the knee is flexed, the MCL can start to restrain forward translation after there's been a significant amount of anterior subluxation. And so this is why the anterior drawer test wasn't sensitive to ACL injury, because essentially with the knee fully flexed, the MCL starts to become a surrogate for the ACL and causes a false negative test. So what we want to do is use something like the Lockman test, which tests for anterior drawer laxity with the knee at 15 degrees, when the MCL, we can see, plays a much lower role in restraining anterior displacement of the tibia. So how do the injuries actually occur? Well, it's not very easy to see or measure during a sporting event how the knee twists to cause a rupture of the ACL. And so because it has this internal rotation component, people have tried to figure out like how this occurs in vivo. And so this particular look is a newer study that uses the bone injury that we can see on MRI to kind of recreate the position of rupture during the sporting event. And so here we have both a sagittal plane view, and then to your right, a frontal plane view. And in the sagittal plane view, we can see here's a normal, non-injured MRI, and we can see the association between the tibial plateaus and the femoral condyles. In the right MRI, or reconstruction, we see that the tibia slid forward onto the femur, and that would give us that anterior displacement that could rupture the ACL. And this here is matching these kind of bone injury spots that were on the femur after the ACL injury. And then if we look here in the frontal plane, we're going to see a twisting, and it's not that easy to visualize in this case, but essentially the twisting requires an internal rotation of the tibia relative to the femur in order to fit the bony contact bruise points together. So this study suggests that essentially anterior translation and internal rotation and slight valgus are associated with the tear or injury position. Now we have another study that used cadaver reconstruction or loading to kind of reproduce the angles that we saw in the videos of some patients being injured. So here's what the injuries looked like right after the rupture. So this is the intertubercular groove in each picture. The arrows point out the proximal and distal ends of the rupture. So we can see here's the ACL portion coming off the tibia, here's the portion coming off the femur, and then so on. So here's the movement pattern that was reproduced in the cadaver experiment. Look pretty close to the video analysis. In the frontal plane view, we see hip adduction, knee valgus, and tibial internal rotation on a planted foot. In the sagittal plane view, we see hip flexion, knee flexion, and therefore anterior shear force associated with compression from the ground. This reproduces the known injury mechanism that we've been reviewing here, both from a theoretical standpoint, when we match up the bone bruise sites, and now we have the cadaver experiment kind of verifying that this internal rotation is associated with the knee valgus. So the prevention strategies then would be to prevent the knee valgus and hopefully stop the internal rotation and anterior shear loads that are occurring at the knee to prevent ACL injury.